All right, thanks, Joe. First, does this work? Perfect. That's going to be hugely important. I went a little happy on the animation, I'm warning you. So if anybody's sensitive to like quick changing images, sit back. So first of all, thanks, Joe, for the introduction. And I first, on behalf of the department, want to congratulate you guys on the tremendous work you're doing. The PPV, PPVBH, and PPR reduction slides really are something else. That beats, our average statewide. It's really helping pull the statewide average towards that 25% reduction that we need. So, kudos to you guys for what you're doing there. And I know, whether it was through these updates or at the Learning Symposium that we had down here back in February, I've seen a lot of what Staten Island is doing, from the data analytics work that Joe and Ani are building and some of that, core back office stuff, down to more, I don't want to say more innovative, but some of the really innovative on the ground care interventions. I know the work you guys are doing with, I think it's with Power Yoga New York, but I'm not sure. The intervention with the opioid dependent young adults in particular was very interesting. And just seeing the spectrum of traditional care interventions down to very community-based, very non-traditional, but saying we're going to invest in this and see if it works. So I think you guys are very much on the right track in a lot of areas. So what I've put together today and what I want to talk about is how to do data analytics in a risk-based contracting environment. I could talk for 4 days about this, so I'm not going to cover everything. I'm going to talk about some kind of broad themes that I think you should focus on as you go into this. And as an organization, whether that's as a mega hospital system or as a single doc practice, what is the information that you need to be able to manage a patient population in a risk-based environment, and how do you get it? Because it's easy to say, oh, I don't do data analytics, I'm not a PPS, or I'm not a hospital system. Data analytics is fundamentally knowing more about your patient population. And you can do that without a server. You can do that without a complex EMR system. Probably not as well or on as large of a scale, but you can still do it. And those themes I kind of wanted to draw across the board. There are tons of DOH bank slides, I will call them, that many of you have seen 90 times before. They're not in here. If you want them, I can send them to you. But I tried to do something a little different. We'll see how it works. So I wanted to go over, I was happy to see in the updates from Mr. Kuhn that there were some different levels of understanding around risk-based contracting, because that's what I'm going to start with. So I first want to start with, an overview of how, payments are made now. So then, I will call it. So this is the past, what we're moving away from, right? And so MCOs, as you probably know, are paid a premium by the Department of Health. It varies based on the patient, but they're paid a premium. And if they can deliver care for less than that amount, they make money. It's their margin. If they deliver care for more than that amount, they lose money on that patient. Pretty simple. So if you're above that dotted line, it's bad for the MCO. Below the dotted line, they make money. Providers generally get paid somewhere under that, right? If on average providers are getting paid more, the MCO would go out of business. So generally providers receive something less and the MCO takes the rest for administrative needs, et cetera. But theoretically, especially on any given patient, the provider revenue can exceed that line. So it's quite possible in a given year that a patient overspends their premium, if you will. So it can go above. And what the provider is spending that money on is a combination of different services. So we have some money spent on preventive services. These are your well care visits, routine tests, et cetera. And then a lot spent on preventable. Now, these are not, there's a note in here to say this is not drawn to scale, but I'm going to tell you right now it's not drawn to scale. But it may be on any given patient. You might spend a lot more, even more than that, on preventable services in a given year. And it's usually those that are going to push you over the line. So if I'm going to go from spending less than premium to more than premium, it's usually because the preventable, the orange, is running out of control. Illustration only, not to scale. You'll see why in a minute, because I'd be over-promising if I didn't say that. So what are we moving to? Keeping this image in mind, right? Where the premium is kind of the fixed amount. Everyone's trying to stay under that. The provider gets something less than the premium, and the provider is trying to keep the orange from growing too much, or the plan and the provider are trying to keep the orange from growing too much. In a value-based payment example, nothing's really changing in the way we, the state, pays the plans. We're still getting them a premium per patient. They still get a total of premium. And instead of provider revenue, we're setting something called a target budget. So if you've watched any of the VBP boot camps or seen any of the, read the roadmap or any of the stuff from the state, you're familiar. A target budget is kind of what we're setting as you hit this or stay under, you're going to get shared savings. You go over, we're starting to talk about shared losses. What we're looking at over time is to see the mix of services shift like this. To go from a model where preventable services are taking up half, if not more, of the target budget. Preventive services are staying relatively flat, and there's really none in there for social services. To move to a model towards the right side of that image, where our preventive have increased. We're spending more money on preventive. We're able to spend money out of a quote unquote Medicaid budget on social services, community-based organizations, that kind of stuff, and preventable have gone down. Now, I can't promise it's going to go down in that proportion, hence why it's, not drawn to scale. But the idea is that, especially on the social services, one of the things we've heard tons of over the years is, I would love to do that for my patients, but there's no code for it. I can't bill for it. The idea of a target budget is that it becomes in your financial best interest to deliver those services with the money that you're paid or out of your own funds, because you know that that additional gap under the target budget, part of that will be yours to keep in shared savings. And that's kind of where that target budget extends. The shared savings under that line is what's split between the provider and MCO. If you're in a loss arrangement where there are shared losses level 2 or higher, then you'd be looking at shared losses above that line. And as Joe mentioned, as both Joes mentioned, that's something not everyone's comfortable with and something that not every provider is equipped to enter into right away. But the shared savings presents real opportunity to start doing what you as physicians know is best for your patients, despite whether there's a code for it. Because it may be much more cost effective and much better for patient outcomes to do, to have a social worker on staff make a few phone calls to the patient for follow-up, that there's not a code to bill for that time. And when you're in a value-based or a volume-based fee-for-service world, I and the Department of Health fully understand why you need to bill for every minute of your time, because the rates are low. And so you need to make sure that you're recovering costs in every single instance you can. Whereas in this environment where it's possible to get paid without submitting a bill, to get paid because you're receiving shared savings reimbursements, much like performance payments from a PPS, you can do some of that more innovative stuff. You can fund the experimental programs. You can start playing around with what you've always kind of known would help the patients, but you never had a rate code for. And then, Joe mentioned, I won't go into too much of this, but the discomfort around downside risk, shared losses. They can become a problem for providers. There are, however, many mechanisms to mitigate that, whether it's stop loss, risk corridors, putting some sort of ceiling on how high those share losses can go. The plans already have some ceilings in place on how much money they can lose. The Department of Health does reinsure the plans. We also have stop loss or kick payments for certain high cost conditions. And you can institute many of those with the MCOs as well. So I wanted to kind of use this as a foundation for why do I need to think differently when it comes to data and information in a risk-based world than I would in a volume-based world. And so we want to talk about some keys to data analytics success. As I said, I'm not going to go into everything in this presentation. It's to give you a taste of where you should start thinking differently. But first, your data needs to be demographically specific. You need to think about not what necessarily the EMR off the shelf says are the 50 important fields to collect on your patients, but what you know about your patients. If you're serving a largely Medicaid population, social determinant data is a little bit more important than if you're serving a upper middle class, largely homogenous community where food insecurity, housing insecurity isn't an issue. Social determinant data might not be as important there. In a racially diverse community, it may be important to know about the racial background of your patients to account for certain instances of chronic disease among those populations. It should be designed locally. So you should think about what, your organizations need. And that's very in line with demographically specific, but make sure that you have input on what you're collecting. And again, you're thinking about, if I'm treating diabetics, what do I need to know? If I'm treating people with behavioral health conditions, what do I need to know? It should be financially quantifiable. This is, I think, something that Staten Island has done a good job of, is striking the balance between we care about outcomes, we want patients to be healthier, but all of this is going to rely on it being sustainable. And for it to be sustainable, we need to know how much money we're saving or not saving. Healthcare is a limited resource. We therefore need to be able to decide where we should direct those efforts to achieve the maximum benefit for health outcomes for our patients. It should be goal-oriented, so know what you're trying to measure to. So I might say, I want to collect data on my diabetic population. That's great, but unless you know what you're trying to move, what is the measure you're trying to improve on your diabetic population? I want better results for my hemoglobin A1C measure. Now I know what I need to measure, and I even know if you're not that far off from your goal and it's been trending upwards for the last 5 years anyway, maybe that's not where you devote your data analysis, because it seems like, you're all indicators are pointing to improvement there. Focus on where, despite your efforts, you haven't been able to crack the code yet. That's what you want to measure, and those are the goals that your data analytics should be supporting. You want it to be iterative, trendable, and evolving. So what I mean by that is, a lot of times EMR systems, data analytics platforms, whatever you may procure or design internally are great when you launch them. And then 3 or 4 years later, you're stuck saying, well, why did we decide to collect this in the first place? I don't need these 7 pieces of data anymore, but I still spend all this money collecting and maintaining them. Make sure that you have flexibility. As new programs come online, as new social factors become important, you'll want to be able to update that accordingly. And that anything you collect should be measurable. This should go without saying, but my experience is it doesn't always. So it's very, very difficult to do anything meaningful if you're collecting data that you can't measure. So when it comes to even something as simple as housing status, we've seen a lot of programs across the state where they have very different definitions of homeless. And so if I have a system that says, a yes-no indicator for homeless, and the patients all say yes, that data collection system may have said, in order to be homeless, a patient cannot have been housed in their own residence where they are the primary, lessee on the lease agreement, versus this person just has to report that they don't feel secure in their housing situation. Those are two very different definitions of homelessness that are both right in certain settings, but to know, is this data measurable and comparable across systems is important. And then finally, that it's clinician friendly. So it's easy for the types, myself, Greg Allen, Joe, to sit here and design an analytics system that, produces all these great dashboards that have a million colors and you can click all over the place and it's fantastic. But if no actual doctor is going to read the information, nurse, social worker is going to read the information and do anything with it, we've failed. So it needs to be clinician friendly in its design and clinician friendly in its application. So those are a couple things I would definitely keep in mind. So I'm going to go through some of them in some other themes in a little more specificity and then turn it over for Q&A again, trying to keep it, just giving you some areas to think about. So as far as understanding your patients, we talked about being demographically specific. So you'll want to collect clinical information. I think that goes without saying. So this is both claims-based as well as information you might be getting from the RIO. I know there's a rep from HealthX here. Information you're getting from the RIO. You'll also want to collect social determinant data. So this is data about your patient's quote-unquote non-medical status, right? Stuff we haven't typically considered to be part of their medical profile, but that we're learning more and more affects their health outcomes, housing, nutrition, education, et cetera. The other thing I would say is challenge the concept of how you define a patient. So we often collect information about the individual. Their family situation and information about their family can be just as important. And unfortunately, most EHR systems, most in-house data analytics systems are based with the SSN or the Medicaid SIN or some unique human being identifier as the unit of analysis. We've talked to many family practices and many CBOs that have really helped us turn that on its head and say, oftentimes the family is the unit of analysis that you should be looking at. If I have, a father, a male, let's say, who has complex behavioral health needs, is an active alcoholic, is in and out of prison, yes, his health outcomes are going to be problematic and I'm going to want to keep an eye on him as a patient. But what about the 3 kids that are living with him? If I don't know to watch for them, I'm going to be surprised when they come in with complex behavioral health conditions, when they are in and out of school, when they're in and out of the criminal justice system. But had I defined the family unit as the unit of analysis ahead of time, I would have seen that coming. And so a lot of times I would encourage you to challenge who you're looking at. It's not just the human being that's the patient, it's the people that are impacted by that human being who either are cared for by or care for that human being. And then I would say also understanding your users. This is back to the clinician-friendly point. So when you're designing a system, when you're thinking about what data to collect, is it small physicians you're catering to, large health systems, or business analysts? So that's, your Staten Island University, Richmond Medical Center, your, smaller local practices that may be specialists, that may be CBOs, that may be behavioral health practices, or is it your office folks? Because those are 3 different user groups that are going to have 3 different needs for the data. So the kind of takeaway here, and I've tried to include one of these for each slide, is designing to the most complex idea, but building for the least sophisticated user. So I want the back end to be, pretty sexy and pretty complicated and, have the ability to be flexible and modifiable as I go. But I want to make sure that the screen that you look at is not something that only a, person with a master's degree in statistical analysis can understand. Because if that's the case, it may be a system that impresses me and Joe and Greg Allen back in Albany, but it's not actually going to do any good. The other thing I would say is, what do you collect? So collect what matters. So when we're focusing on which data we're going to collect, what data we're going to take into our system, it's number one, know your contract goals. So know what you're being measured on. If you're in a risk-based contract, you better be collecting every single measure in that contract, and I would question why you're collecting measures that aren't in it or don't affect the measures in it. So really think about, what measures are you being measured on when it comes to your contracts, or, DISRIP would be another set of measures that obviously you guys have done a good job of saying. When Joe and folks designed the analytic system in Staten Island, they didn't say, here are 50 measures that I think we should collect and hopefully they'll align with what DISRIP is paying on. They said, let me start with what DISRIP's paying on. That's what I'm going to track. It should be the same in value-based payment contracts. Perform constant ROI. You can't focus on everything. Your attention is a limited resource. Healthcare is a limited resource. Decide which measures are going to earn you the most money in shared savings, where you have the combination of most money and best chance of achieving them, and focus your analytic efforts on those. How do I move this needle from 50% to 70% if crossing that threshold gets me a performance payment or shared savings? And then obviously, classic data analytic problem is understanding causation versus correlation. So there's a lot of things in your data that may look like they're affecting another thing, but really, this is where consultants can help subject matter experts, and those subject matter experts are in many cases native to your organization, and they're called your nursing staff, who know that, you may think in the data that this causes this, but that's not how it really works. What really, I can tell you what causes that, and it's poor discharge planning. It's not the complexity of the patient condition that causes them to stay for 4 days in the inpatient instead of 2. It's the fact, and it wasn't Staten Island, I think it was one of the ones in the Capital District. They did a study where they falsely concluded that a bunch of patients were, they were trying to find out why these patients with whatever condition they had were in the hospital like twice as long as a group of other patients were, like 4 days instead of 2. And they narrowed it down to it's because their admission happened on a Thursday, which meant that their discharge was not happening on Saturday or Sunday. They were waiting until Monday. So it was the problem of admitting patients on Thursday, not any complicated medical or pathological explanation. So sometimes looking at things as simple as, if you admit someone on a Thursday and they're not getting out on Friday, I can tell you they're not getting out till Monday, because we don't have the operations staff to discharge over the weekend, and that's a problem. So that's what you would look at. Employ creative solutions to that. So proxy measures. This is especially if you don't have all the data that you would want. What are some things that tend to be good indicators of another measure? And there's been a lot of research done on this. I know DOH will be putting more out around this. And notice early indicators as well. So where can one measure stand in for another measure, even if you can't get that measure until the claims records have been pulled and the statistical analysis has been done. So really get creative. And this is another place where talk to your patient-facing professionals. I will often know. If I'm a nurse, I will often know, or a social worker or an intake coordinator, I will know which patients are going to have that problem based on this. What are they looking for? And see if you can find a way to capture and measure that in your data analytics system. So that's kind of the point there. The takeaway on this one is, basically what gets measured gets moved. If you as an organization start paying attention to something and putting information about it, people will work on changing it. If you don't start communicating internally what that measure is versus the goal, no one will work on it. And so it's very important to pick your kind of core set of what you can digest, a certain group of measures that you want to improve, and then communicate often about what those measures are, what your progress as an organization is against them, and where you want to go. So build from actionable and descriptive data to predictive data. So I just define, and this is not like from a dictionary necessarily, but I define actionable, at least, as brief info about what just happened. So I want to know that I'm a PCP. My patient was admitted to the ER last night. I want to know that. It's actionable. I can do something. I need to follow up with that patient, find out why they were there, what went wrong, et cetera. Descriptive info is broad info about what happened next. So the claims history from that month. I will find that the patient never filled the prescription they were supposed to fill that I gave to them because there was no claim for it. They then showed up at the ER. You know, there's a path of events surrounding that actionable piece of info. And eventually that's helping me build predictive info, what will happen, right? So maybe in the future, I want to know when a claim never dropped for that person's behavioral health meds because it means they never filled them. And so if I have a bipolar patient who hasn't filled their lithium, I might want an indicator about that because if I look historically at the actionable and descriptive information, it will tell me 9 times out, well, not 9 times out of 10, but when patients have not filled, when my bipolar patients have not filled their lithium prescription, there's an increased likelihood that something will go wrong in the next 3 months. And I can look even for the absence of a claim as an indicator that something has happened, as the absence of a prescription fill for that patient. Changing the source to match the use can be pretty important here. So this is where you're looking to the RIO. You may be looking to, instead of just claims data coming from the state or from the PPS, as the case may be. Integrate multi-channel info, and Staten Island's done a good job of integrating the RIO information. You may need to look to more real-time sources of data than the state will ever be able to provide to give you that type of actionable info. One of my big charges, which I know Joe has heard from me before, when I took this role at the state, is we deal in millions and millions and millions of rows of claim information. We're getting it from multiple payers who are getting it from multiple providers. I am never going to be your better care management platform. Don't wait for me as the state to tell you that a patient was admitted to the ER last night, because I will tell you, but last night was 6 months ago. And so I'm going to come running down to Staten Island. I'm going to say, oh, look, this patient was admitted to the ER. And you're going to say, yeah, and they're not even our patient anymore. I don't know what happened to them. That was 6 months ago. So look to other sources of data. We can tell you great things when it comes to descriptive. I can give you the complete picture of what went on all around that ER admission 6 months ago, so you can use it to decide what to happen next. We're good at that. But other sources are better at what just happened last week. So think of looking there, because ultimately great data too late can be useless. Compare sources across time. It's really important, and this is where an organization like a PPS can help you, is starting to look at comparing the sources over time. So were the action alerts I was getting from my RIO lining up with the claims data when it did come in 6 months later? So, testing the systems against each other for accuracy, and I say this with Healthix in the room, but I think you guys are confident that, you're basing that off of actual clinical information that's being transmitted. But to give you a sense of what is your lag time, how often are you getting those alerts relative to when it actually happened, you can use the systems to reconcile each other. Refine that approach. So learn, is the lithium example I gave a good one? Or are there other instances where there's a stronger correlation between the absence of a behavioral health prescription fill and something bad actually happening? Because you don't want to follow up or create a whole a clinical intervention protocol when 99 out of 100 times nothing happens. You want to create a clinical intervention protocol when something often goes wrong based on the absence of a prescription fill. So you can decide what makes sense once you see that data. And constantly compare it to reality. So again, if you're not hearing anecdotally from your physicians on the ground that this is helping or that there's a real problem, don't let the data necessarily drive you too far down a path that no one's validated. Because the descriptive and the actionable data can help you get to predictive. So I have a few more minutes and I'll go to Q&A. I think we're almost done. Know your strengths. This is where it's really important to get in. When you're getting into value-based contracting, you need to know what you as an organization are good at. And the Staten Island PPS has done a good job of capturing what it as a network is good at. So, learning how to replicate that when it comes to your organizations getting into value-based contracting. Where am I strong? Because it's important to know from a business case, when you walk into a negotiation with a payer or an IPA or an ACO, to say, I'm really good at moving the needle on this quality measure for this type of population. When it comes to diabetes patients, I know how to handle those, et cetera. I can look at my historical performance and I can point to clinical outcomes. I help move the needle on these patients from here to here. And if you give me a similar cohort of patients attributed to me in this value-based contract, I'm confident I can do the same, which will earn shared savings for me and for you. So going in and making that value proposition to the other negotiating partner. As Joe said, early negotiations are the best ones. And second to early, I would say, or maybe even greater than early, I would say informed negotiations. So when you know what you can offer to the other party, in terms of I improved this patient population from here to here, and I'll do it again if you let me, is a very strong position for you to be in when you get into those arrangements. And you should also know your opportunities. One of the great things about value-based payment is in an area where your patient population is already at a low level of efficiency or quality, you have a lot of ground to make up. And where there's a lot of ground to make up, there's a lot of opportunity for improvement. Large gaps mean large potentials for shared savings and performance payments. So, I think that if you look at even the PPR, PPV graphs that were shown earlier, you can make tremendous improvements when you start from a baseline that's not exactly where the state wanted it to be. And then we've seen that across the state, not to take away from the great work that's been done here, because the percentage increases are, much greater than we've seen in many other places. But the point is, knowing where you have a high rate of complications, where your patients are usually utilizing preventable services like crazy, and where even the rate structure, when it comes to pricing, might not be as advantageous. The patients are using expensive services. You can use that to your advantage to say, if I was incentivized in the right way, in a value-based payment contract, I could really make some change here because the way that patients are consuming services is not the most efficient. And this is a way of saying that, the performance payments that PPSs were getting were enabling them to do the innovative type of care delivery that was starting to move the needle and has moved the needle since. Shared savings is the performance payment of the future, right? That being able to harness some of that shared savings that's not tied to any specific service, that I don't need to bill for, that I don't need to drag a patient in for a follow-up that they may not actually need. That's the money that's going to help you do the data analytics, that's going to help you do the population health management and the creative interventions that may not have a rate code associated with them. Greg Allen says crawl, walk, run a lot. Really means do something now, even if you can't implement the full vision now. Build from what you have. So if you have an Excel-based tracking system where you look at patient data, use that. Start somewhere and start saying, how can I use the data I have at my disposal to give me some insight into my patients and what I'm doing? And avoid potholes. So collect and design at the same time. A lot of times you can get into that bind of, I have in my head what the perfect data analytic platform is going to look like, and in 7 years, I'll be great. So you don't do anything or measure anything for 7 years, and you can't afford to do that with real people walking through the doors of your facilities every day. Avoid analysis paralysis. So I have too much information and I don't know what to do with it. So I just get confused because one of it tells me to do one thing and pick what you're going to listen to, try it, and see if it works. And remember that no data is perfect. So we have data sources with problems, whether it comes from what we have at the state, what we're getting from the plans, what you guys have in your own systems. Learn to work with good enough. And remember, this is a quote that one of the other PBSs used at the Learning Symposium, and I forget which one, but there are many things that are true but not important. And avoid distracting data. So I can make a whole bunch of charts about how patient eye color may or may not correlate with complications from diabetes, but we know that it doesn't mean anything. Like, I can make charts until I'm blue in the face, and I'm actually quite good at that, but it doesn't mean that it's useful information that's going to change the way that you deliver care. So avoid, chasing after data that's true but not important. I included this here to give you a sense of what we're building at the state. You will never be able to digest this from far away, but these are the types of analytic deliverables that we're starting to put out. I'm just going to give you a brief overview, and then I'm sure that we could share this PDF with anybody that wanted it if you want to take a closer look. But just to give you a sense of the stuff that we're going to be putting out there for contractors and PPSs and people in value-based payment arrangements to digest. So we're calling this our Opportunity Overview Dashboard, and I really like this one. I think it's one of our better examples of how you can use information that the state has to decide where to focus a VBP arrangement. So what this does is along the y-axis, so up and down on the side, it creates a row for the different episodes. So we have different chronic conditions along each row. So we've got, I know nobody can probably read this, but we have low back pain, gastroesophageal reflux disease. We have bipolar disorder, osteoarthritis, etc. The size of the dots on the graph there represent how much money is spent in that episode. The larger the dot, the more money is spent. You also can't see because we're selected on one right now, but the dots range in color, which you can kind of see over there, the color spectrum from light blue to dark blue. The dots range in color by what percentage of that money is spent on complications. So we might be able to say that in a certain condition, let's say osteoarthritis, only 20% of the money goes to complications, avoidable complications. The other 80% is standard. It's going to happen really no matter what happens. It's going to be a lighter blue. But I can tell you that schizophrenia tends to have a really, really high rate of complication spend. That's going to be a very dark blue. It's going to be like 80%. And then finally, the x-axis, it measures the coefficient of variation, which is a complex way of saying how different is one patient from another when it comes to spending. So the further it is to the right, there's wide variance. Some patients are spending almost nothing. Some patients are spending tons, and we have a lot of variation around the mean. The ones on the left are tightly grouped. So there's really not too much difference one patient to another. So what am I doing with this? If I was a clinician, what would I do? I would look at this and I would say, I want a large circle that has a lot of spending in it. That's dark blue because it has a lot of complications. That's way over on the right because there's variance all over the place. That's what I want a VBP contract for because that's where my shared savings is. That is something that I can move with better patient engagement, with better upfront clinical intervention. Whereas something high on the left, that's light blue, there's not much I can do. I mean, care is expensive and care takes time to deliver. That's what that dot is telling me. So we're starting to put things out when we roll out different releases of MAP that will give this information to parties like Staten Island compared to other PPSs in the state that will enable them to say, where are we strong? Where could we improve? And what can we use? How can we use that to inform what VBP contracts we should get into? So we could do a whole session on that, but that's not right now. But I just wanted to give you guys a sense of what that looks like. And with that, we can take some time for Q&A. I think I went like 5 minutes over. So. I guess so. I don't know if I can do anything about that from up here. But. Anybody have any questions? Yeah, I think it's a great point. And I think when you're saying data, we really mean like measured disparity often between the CMS program, the state, and which state program, VBP, APC. There's a lot out there. I think that sometimes it's easy to get, so I'd say two things to that. One is sometimes it's easy to get lost in measure definitions. And a lot of the measures that I've seen in the CMS programs versus the Medicaid programs versus APC, they're different if you look at the measure definition. But at the end of the day, they're not really that different when it comes down to, I'm trying to increase the number of schizophrenic patients that are taking antipsychotic meds. The number of days that are required in the measure numerator might be different. So sometimes what I found helpful is to abstract from the actual measure definition down to, this is increasing medication adherence amongst people with behavioral health disorders. And I can pick 2 measures from my CMS measure set, 1 from my Medicaid measure set, and 1 from APC that all drive at that fundamental goal. Now, just because I passed that fundamental goal doesn't mean I would have complied with the nuances of each specific measure, but sometimes it's easier to create almost like a measure crosswalk on the internal side to have your more core measure coder and data analysis people say, I'm going to take these 5 measures from these 5 sources and all call it better medication for people with BH disorders because it's pretty much the same thing. That's number 1 as a short-term solution. Number 2, I would say the state is trying to align as much as we can our VBP program with measures that are coming out of APM in Medicare. So we are paying a lot of attention to what Medicare is finally clarifying on some of their APM measures so that we can get that alignment because, Medicare is often the driver of the market when it comes to measurement, and we recognize that. So we're looking to work with providers and plans on, you know, hey, if we modified these 3 CAG measures to be these 3 measures instead, because we think it aligns better with APM, you know, how would you feel about that? So the secondary answer to that is we are working on bringing ours that align with Medicare. Hopefully that will help a little bit. Anything else?
Questions for Jason? It was terrific. Thank you.
Yeah, no problem.